This morning I'm going to discuss some of the unusual manifestations of lung cancer. With 150,000 newly diagnosed lung cancers in the United States alone every year, you are likely to see lung cancer presenting in an unusual way. This is particularly important when lung cancer masquerades as benign disease. First, let's review some of the common manifestations of lung cancer. A pulmonary nodule or mass is very common. 70% of large cell carcinoma will present this way, 60% of adenocarcinomas, and 40% of squamous cell carcinomas. Post-obstructive pneumonitis and segmental or lobar atelectasis is also common. 17% of squamous cell carcinoma will present as segmental or lobar atelectasis. A central or hilar mass is something that is commonly seen with squamous cell carcinoma and small cell carcinoma. As adenocarcinoma is changing its character, we're seeing hilar masses in adenocarcinoma with more frequency, in some reports up to 50%. This patient on the right has a peripheral spiculated nodule. This is an adenocarcinoma. This patient has the classic findings of left upper lobe collapse. You can see indistinctness of the left heart border and the left upper lobe plastered against the anterior portion of the chest. This was due to a squamous carcinoma. This is the same patient. You can see the hilar mass obstructing the upper lobe bronchus, but with patency of the superior segment, lower lobe bronchus, and collapsed and drowned lung peripherally. The patient on the right presents with symptoms of pneumonia and radiographically has a superior segment right lower lobe consolidation. A month later, this is not cleared. We still have consolidation of the superior segment of the right lower lobe. And for further evaluation, CT prior to bronchoscopy shows mucoid bronchograms out in the somewhat collapsed but mostly drowned and consolidated lung with truncation of the superior segment bronchus in this squamous cell carcinoma. This patient has a somewhat subtle hilar mass. You can see the hilar cancer on the right, and this one is an adenocarcinoma. Again, we're seeing hilar carcinomas with adenocarcinoma as the cell type more commonly. The unusual manifestations of lung cancer, I'm dividing them into mediastinal, bronchial, pleural, and pulmonary abnormalities. In terms of mediastinal abnormalities, we sometimes see lung cancer presenting as a mediastinal mass. Lung cancer can present with esophageal symptoms, pulmonary artery problems, sequelae of superior vena cava obstruction, and pericardial or cardiac invasion. Mediastinal mass is very common in small cell carcinoma. 80% of cases show mediastinal and hilar lymph nodes on chest x-ray. Often the bronchial primary is too small to see. These primaries are proximal, but they tend not to obstruct the bronchus, and instead submucosal spread is rapid to the mediastinum. Often the sputum cytology will be positive, and as these are neuroendocrine in origin, hormone secretions such as ACTH can also be presenting manifestation. Primary mediastinal carcinoma is something that people talk about. Generally, this is when a mediastinal mass is histologically characteristic of lung cancer, but a primary cannot be found, and it is not a small cell carcinoma. Some think this is a thymic origin. This is a gentleman in his 40s who presents with clinical superior vena cava obstruction, and you can see the large anterior mediastinal mass and right paratracheal mass. There's no hilar mass evident. On the lateral view, again, no hilar mass is evident, although one can see the superior mediastinal mass. And at CT, there was no hilar mass. However, there's this large anterior and right paratracheal mass obstructing the superior vena cava. The differential here would be primarily lymphoma and small cell carcinoma. And when we biopsied this, it was small cell carcinoma. Lung cancer can present with esophageal symptoms. This can be due to either local invasion, especially from the left bronchus, or mediastinal metastasis. The patients can present with dysphagia or obstruction. When there is obstruction, often there's symmetric stricture with smooth borders, but this can be confused with esophageal carcinoma. An achalasia picture also may occur due to invasion of the myenteric plexus. Lymph nodes often displace and compress the esophagus. They don't often narrow the esophagus. However, direct invasion can occur. This patient on the right has a right-sided lung cancer with phrenic nerve paralysis. You can see the elevated diaphragm. And here's the esophagus, which is completely obstructed. A spot view shows extrinsic compression and obstruction of this esophagus due to mediastinal metastatic disease from lung cancer. Pulmonary artery invasion is not uncommon. The main pulmonary artery is involved in approximately 18% of patients with bronchogenic carcinoma. Lobar and segmental pulmonary arteries are involved in over half the patients. The invasion can be direct, or it can also obstruct the pulmonary artery from compression or tumor emboli. When a lung cancer causes infarction, one can see this dumbbell-shaped appearance where the peripheral mass is due to infarction and the central mass is the cancer. For biopsy, remember that the peripheral lesion will be non-productive and you should go for the central lesion. Also clinically and on nuclear medicine studies, pulmonary artery involvement can mimic pulmonary emboli. Superior vena cava obstruction can result in findings that present as unusual manifestations of lung cancer. 80 to 85% of superior vena cava syndromes are from lung cancer. Patients with small cell carcinoma in some series, 9% of these will have superior vena cava obstruction. Chest x-ray evidence of collateral venous pathways include an enlarged azygos vein and an enlarged left superior intercostal vein. Esophageal varices can occur due to superior vena cava obstruction. These are located in the mid and upper esophageal regions, and they are downhill in their path, bringing blood from the upper extremity to the inferior vena cava. These varices can cause esophageal bleeding. This is our same patient with small cell carcinoma on the right, and you can see this collateral pathway through the left superior intercostal vein, which will be bringing blood from the left brachiocephalic vein to the left hemiazygos vein. When I see pericardial effusions in patients with lung cancer, this tends to be quite an ominous sign. Unlike pleural effusions, which can be present with resectable carcinoma, pericardial effusions, in my experience, usually mean metastatic disease. About 10% of lung cancers are seen to metastasize to the heart or pericardium. This can occur due to direct invasion across the pleura or pericardium. It can also result from invasion into the pulmonary veins and then into the left atrium, and due to hematogenous or lymphangitic spread to the pericardium or into the heart. Interestingly enough, a pericardial effusion has been seen as the presenting clinical feature with lung cancer, and the type of invasion in the pericardium can be seen as generalized, localized, or nodular pericardial thickening. Lung cancer can present with bronchial abnormalities that are sometimes difficult to either clinically or radiographically appreciate, or they can be confusing. Tracheal carcinoma is an unusual type of lung cancer. Bronchial wall thickening can sometimes be subtle. Mucoid impaction, obstructive hyperinflation, and the double-lesion sign are all unusual presentations of lung cancer. Tracheal carcinoma is very uncommon, less than 1% of all thoracic malignancies. More oftenly, the trachea is invaded by adjacent bronchogenic carcinoma. Most tracheal carcinomas, which are primary to the trachea, are squamous cell. These are associated with smoking abuse. Often they're diagnosed late. They may have extensive local invasion to the mediastinum and esophagus, and may present with tracheoesophageal fistula. These are more common in the 5th and 6th decades of life. Adenoid cystic carcinoma is still a common type of tracheal carcinoma. These are slowly growing and often invade the submucosa. They're more common in the posterior wall of the lower 2/3 of the trachea, and are more common in younger patients in the 4th and 5th decades. CT and MR can be very useful in planning the surgery, and with all kinds of tracheal carcinoma, the diagnosis may be delayed. Often the patients present with symptoms of asthma, dyspnea, hoarseness, cough, stridor. The wheezing should be with inspiration if it's proximal to the thoracic inlet, and expiration if it's distal. This gentleman on the right presented with what appeared to be asthma to our chief of pulmonary, and I'm sure that he did not miss wheezing on inspiration versus expiration. The patient responded well to bronchodilators, but came back to the emergency room with extreme shortness of breath, and at that time we noticed this tracheal carcinoma. This was a squamous cell type, and this patient has done very well with surgery. Bronchial wall thickening can be a very subtle early sign of lung cancer. It's also nonspecific. A thickened bronchus intermedius can suggest a right hilar mass. However, this is also seen in common entities such as bronchitis and pulmonary edema. The bronchial cuff or anterior bronchus sign is seen as a thick end-on bronchus, which often obscures the associated artery. This is more common to be seen in the perihilar regions or the anterior segment of the upper lobe on either side. This is also a nonspecific finding, and it may precede the obvious mass by years. Now, I'm sure all of you from the back can appreciate this thick-walled upper lobe bronchus, and that we're obscuring the adjacent artery. Well, we didn't appreciate this, but a year later, the patient returns with a spiculated mass in this region, again adjacent to the upper lobe artery, and by CT you can see how there's thickening of the bronchus and obscuration of the artery adjacent to it. Mucoid impaction is seen with asthma, cystic fibrosis, congenital atresia of the bronchus, but in the proper clinical setting, a patient over the age of 30 years old, a smoker, if you see mucoid impaction, you should suspect lung cancer. Some of the descriptions that are used for mucoid impaction are gloved fingers, branches, bunches of grapes, V or Y shapes that point toward the hilum. This is most commonly seen when the obstruction is a segmental branch. This is because rather than collapse, you will get collateral ventilation occasionally, and the lung around the bronchus will be aerated. However, it has been noted with lobar or mainstem obstruction, and the ways in which the adjacent lung is aerated is unclear. If you choose to biopsy this lesion, the bronchial plug may contain tumor. This is a patient with cystic fibrosis showing the classic gloved fingers here with mucoid impaction. If he didn't have cystic fibrosis, this is a gentleman in his 40s, you should suspect lung cancer. Obstructive hyperinflation is uncommon, although it would probably be more common if we did inspiration and expiration views on all our patients. In any patient with a unilateral wheeze, clinically, lung cancer should be suspected. And remember, chest x-ray and CT is not the only way to diagnose lung cancer. Sputum cytologies and bronchoscopy are very complementary and often will show the central endobronchial lesions that we cannot see. Decreased perfusion to the area that's obstructed may also cause a hyperlucent lung, and rarely you will get overdistension with a check valve type of obstruction. This is an earlier film on the patient I showed you at the very beginning of my talk with the left upper lobe collapse, and this is a year before, and there is hyperinflation of the left upper lobe, or at least diminished perfusion of the left upper lobe. The double lesion sign refers to the fact that lung cancer usually involves a single bronchus, and so if you have bronchi that are not adjacent to each other, that are involved with disease, we often suspect benign etiologies. However, disease of unassociated lobes or segments can be seen with lung cancer with variations in bronchial anatomy, invasion through a fissure to obstruct an adjacent lobe, multiple primary carcinomas, and this has also been seen with a primary carcinoma in one lobe and an inflammatory or metastatic disease in another. This is a patient with a very poorly differentiated carcinoma of the lung invading the superior vena cava, and you can see involving both main stem bronchi. This patient could easily present with a double lesion sign. Pulmonary abnormalities include spontaneous decrease in size of lesions, calcification of bronchogenic carcinoma, thin-walled cavitation, air crescent sign, alveolar patterns, multiple nodules and masses, and satellite nodules. Remember that most lung cancers will double between 1 and 16 months, and spontaneous regression is very, very uncommon. However, transient decrease in size does occur with some frequency. This can be due to transient necrosis of a portion of the tumor, improvement in adjacent consolidation, and improvement in the patient's immune status. Therefore, even though a nodule or pneumonia appears to be improving, you should continue to follow it up to complete clearing, because these uncommon cancers that transiently decrease in size should show continued regrowth. Calcification is seen very commonly histologically with lung cancer, but not commonly with plain chest x-rays. This occurs due to dystrophic calcification or engulfment of a granuloma. Calcification is much more commonly seen on CT than chest radiograph, and has been noted in adenocarcinomas, bronchiolo-alveolar carcinomas, and large cell carcinomas. Remember that benign calcification is dense diffuse calcification of a nodule, central core type of calcification, laminated calcification, or popcorn type calcification. If the lesion is over 3 centimeters, is spiculated, lobulated, or grows with time, despite what you think of the calcification, you should still suspect carcinoma. This nodule on the right is about 2.5 centimeters, and you should worry about cancer, except that it's diffusely, densely calcified, and you can be reassured that this is benign granuloma. This is a patient with squamous cell carcinoma and a little central calcification. You wouldn't mistake that for benign disease. This is over 3 centimeters. The patient on the right has another squamous cell carcinoma with some calcification and a little peripheral cavitation. And this is a patient that has engulfment of a granuloma by an adenocarcinoma. Thin-walled cavitation is said to be most commonly seen with benign disease. Remember that approximately 10% of lung cancers cavitate. Usually these will be thick-walled cavities, and you may see mural nodules. If the wall is less than 4 millimeters in its maximum thickness, the group from Kentucky has shown that these will usually be benign. However, 5% of these will still be carcinoma. So in patients over 35 years of age, they recommend continued close follow-up of these cavities. This is an elderly gentleman in our veterans nursing home who presented clinically with a pneumonia and lung abscess, but really was suffering from his severe coronary disease. You can see on CT this is a very thin-walled abscess. The patient died shortly after this film, and this was found to be a lung cancer. We can see some lymph nodes that actually were inflammatory at postmortem. Air crescent signs are generally seen with benign disease. However, occasionally intracavitary tumor mass, debris, or fungus ball can be seen with lung carcinoma. If the walls of the cavity are nodule, if the air crescent is inferior, if the wall is seen to thicken over time, or if there was lack of a pre-existing cavity, lung cancer should be suspected. Cancer can also grow within the wall of a cyst or bullae. The thick wall or fluid can also be seen with hemorrhage or infection and is a nonspecific finding. This patient on the right has a little mass in the right paratracheal area that has a small air crescent. And supine and prone CT scans show this to be a fungus ball in a pre-existing tuberculous cavity. This patient has a large cavity and a hilar mass. and this was unresectable carcinoma. One can see several months later that this mass is growing into the cavity or bulla and producing an air crescent sign that could be masquerading as benign disease. The CT on this patient again shows the large cavity several months later with the tumor growing into the cavity. Airspace disease is generally felt to be due to benign disease. However, one can see this particularly with bronchiolo-alveolar carcinoma on chest X-ray. Air bronchograms on CT are much more common in lung cancer than they are with chest X-ray. Bronchiolo-alveolar carcinoma has been noted by the group from Korea to narrow and stretch the bronchi as opposed to chronic inflammatory disease where the bronchi are often tortuous. Bronchiolo-alveolar carcinoma can be seen as focal, multiple, lobar, or diffuse disease. Usually it presents as a chronic nodule mass or consolidation, but it may progress very rapidly. The CT angiogram sign, we can see an example on the right where you can see vessels coursing through this low attenuation area of consolidation in this patient with bronchiolo-alveolar carcinoma is a sign that favors cancer. However, it can be seen with benign disease such as pneumonia. Bronchuria is also seen fairly commonly with bronchiolo-alveolar carcinoma. The CT angiogram sign is probably due to the fluid which fills the airspace and does not distort the lung underneath. Air bronchograms that are seen on CT, these are seen much more commonly with lung cancer. This is particularly useful with small peripheral lesions. If you think the patient has a pneumonia and you see a large area of consolidation with air bronchograms, seeing the air bronchograms on CT should not suggest that it's cancer. However, small peripheral lesions, most granulomas and hamartomas will not have air bronchograms, and a high percentage of adenocarcinomas and some other carcinomas will have air bronchograms, so this should suggest lung cancer. This is a patient with bronchiolo-alveolar carcinoma who had this disease for several years. This was towards the end of his life, although he still had 6 months left to live, and you can see these air bronchograms in the involved lung. You can also see air fluid levels in the trachea and bronchi. This was due to his bronchuria, which was one of his major complaints. This patient had a small peripheral lung lesion, and you can see the air bronchograms within it. This should suggest lung cancer. This was an adenocarcinoma. I have seen this finding also with inflammatory disease, or in this patient on the right where you can see air bronchograms in this peripheral density, which was worrisome on chest X-ray for a new lung cancer. In this patient, it was due to hemorrhage from a pulmonary embolus. You can see the embolus, the large saddle embolus on the right, and on the left, this is the small embolus leading up to the segment which had the hemorrhage and air bronchograms. Multiple nodules and masses can sometimes be confusing. They may delay the diagnosis because infection or metastatic disease is suspected. Multiple synchronous primaries have been reported in up to 3.5% of carcinomas of the lung. At the Veterans Hospital, it seems to me that we're seeing them even more commonly than this. Metachronous tumors are very common, up to 30% of patients. Remember that lung-to-lung metastases are not common in early disease, and although up to 10% of patients with lung cancer may get lung-to-lung metastasis late in the course, this is usually in the presence of distant metastasis. So remember that if you see a new nodule in someone who has had lung cancer that was resected, that this patient should be worked up for a new primary carcinoma. Bronchiolo-alveolar carcinoma may present as multiple or numerous nodules, and satellite nodules, although usually seen with benign granulomatous disease, can occasionally be seen with lung cancer. This patient on the right has bilateral resectable lung cancers. You can see on the left, this is post-obstructive pneumonia due to an endobronchial lesion that was diagnosed at bronchoscopy. That was a squamous cell carcinoma. This adenocarcinoma on the right with a little satellite lesion we diagnosed with percutaneous fine needle aspiration biopsy. This is a patient with interstitial fibrosis who underwent a high-resolution CT scan, and we inadvertently found bilateral squamous cell carcinomas. Although adenocarcinoma is more commonly reported with chronic inflammatory disease, these happen to be squamous cell carcinomas. This is a patient with silicosis, World War II veteran that had been in the rock mines for many years as a prisoner of war. You can see his eggshell calcifications in his hyla, and we did his CT because of this left upper lobe mass that was a squamous cell carcinoma, but we also inadvertently found an adenocarcinoma on the right. And this veteran has had a left upper lobectomy for lung cancer, presents with a small right upper lobe nodule. Remember, this is potentially resectable, and in this case was a resectable adenocarcinoma. This patient is a Vietnam veteran who presented with what we thought was probably a nipple shadow, but tried to get the patient to return for nipple marker views. When he returned 2 years later, he had at least 2 nodules, and at this time he was reviewed, and we tried to get him to return for biopsy. 6 months later, when he returned for biopsy, he has diffuse nodules throughout both lungs. This is where his original nodules were. And this is an example of bronchiolo-alveolar carcinoma growing very slowly over time, as it often does typically, and then suddenly progressing rapidly. Lymphangitic carcinomatosis. I have seen 2 cases this year of lung cancer presenting with both signs and symptoms and radiographic appearance of lymphangitic carcinomatosis. Remember that lung and breast are the most common primaries, so if your patient is a man, lung will be the most common primary. Especially with unilateral lymphangitic carcinomatosis, lung is the most common etiology, and the signs, symptoms, and radiographic appearance may simulate pulmonary edema. Sorry. This patient, in retrospect, had a new vague density in the right upper lobe, and 6 months later presented with increasing shortness of breath. The clinical concern was heart failure. However, you can see this diffuse reticular change in the right upper lobe. On the lateral view, you can see it's confined primarily to the right upper lobe. The CT scan shows thickening of the fissure, interlobular septae, thickening of the bronchovascular bundles, and nodularity along the bronchovascular bundles. This is very typical of lymphangitic spread of carcinoma. The primary here was an adenocarcinoma of the lung. Lung cancer can present with pleural abnormalities, spontaneous pneumothorax, a diffuse nodular pleural tumor pattern, and isolated pleural effusion. Spontaneous pneumothorax is very unusual and usually is seen in advanced disease only. The mechanisms can include hyperinflation with rupture of a bleb, but more commonly this is with a very large peripheral tumor where necrosis and a bronchopleural fistula develop. Diffuse nodular pleural tumor may masquerade as malignant mesothelioma. Although you usually will see the primary tumor, this primary may be subtle, and the cell type is usually adenocarcinoma. An isolated pleural effusion is not uncommon with bronchogenic carcinoma. In fact, lung cancer causes 33% of malignant effusions, with breast cancer being second in line. The primary lesion, however, may be subtle, and if the effusion is very large, you would expect to obscure the primary lung cancer. So at our institution, if we're going to image a patient with, particularly in a man where the likelihood of lung cancer is fairly high, we image them after the effusion has been drained as much as can be done. So in summary, when you're out practicing the art of radiology, which is often a very rushed business, remember some of the uncommon presentations of lung cancer, which is a common disease. Thank you.